So what I want to talk to you about today is a topic that prevails in my private practice, and I'm in private practice 4.5 days a week with limited teaching at the University of Pennsylvania in the residency, but primarily I am a private practitioner dealing with the same types of referrals, general practitioners, and patients as most of you. And something that has really taken hold over the last 10 years, and especially the last 5 years, is immediate tooth replacement in the aesthetic region of the dentition. And so we're going to talk about a few different aspects of that hopefully you can take a pearl or two home with you that will help you conquer this the way that I'm still trying to conquer this situation. And in 2015, in the Journal of Aesthetic Dentistry, I co-authored a paper with Sergio Rubinstein, who I'll be speaking with at this meeting on Monday, and Dr. Louis Rose, talking about some of the nuances of achieving aesthetic results with immediate implant therapy. And we can't ignore these. If we skip any of these steps, we are probably going down the path of failure. But diagnosing and treatment planning has to be the #1 step that we all are committed to. Looking at case selection, when to perform immediate tooth replacement, choosing the right implant, which we're going to focus on quite a bit, augmentation, the long term has to be in mind throughout the treatment, and talking a little bit about implant stability. And what we know from a healed site is when a tooth is extracted and we know that that socket will fill with bone and will heal, but it's not going to heal in a squared off flat ridge in most cases, but we're going to have a more apical position of that buccal crest relative to the proximal and the palatal bone. And the realities of a healed site would be that we have the option to place the implant more flush with the palatal bone, causing us to have to do some augmentation on the facial. We can place the implant more flush with the buccal bone, but then we're going to have the implant possibly placed too deeply for long-term aesthetics and bone maintenance. Or we have the option to place an implant in a position where it is even with the bone in 360 degrees using the profile implant. And what we know from the literature is that placing an implant into an extraction socket by itself is not going to preserve the dimensions of the ridge. We know from people like Tom Wilson that yes, that gap will fill in with new bone, but we're still going to have diminution from the buccal where that facial plate of bone is going to be in a more apical position relative to implant placement on the palatal and proximal surfaces. And we've seen this in animal studies with experimental types of defects, where when an implant's placed in a circumferential defect, that yes, it will fill in with new bone, but we're still going to have a lower position of the facial bone relative to the lingual or palatal plate. And how does this impact our aesthetic treatment and our aesthetic treatment planning? And so when we look at how tissues heal at time of extraction, we know that by 8 weeks in the dog model that we will have a bridge of new bone over the crest, but we're going to lose some of the height toward the facial. And an example clinically would be a situation where I had previously extracted tooth number 3, grafted the site with a bone allograft and a collagen membrane, and went back at about 4 months to place the implant. And so looking at this radiographically, we have some decisions to make. Knowing what we know about a flat top implant, how is this going to impact the surgical procedure that we as periodontists are going to perform? We can place the flat top implant flush with that distal bone and more towards the facial bone, but we may have to do some bone removal to have that implant connect to the healing abutment and the restoration. Or do we have the possibility now to place an implant that has a bevel where the slope is about 1.5 millimeters on average, and we can orient that bevel distal buccally and not have to take any of that bone away and preserve all of that hard tissue? And so that's exactly what I did in this situation. Picking the implant is a huge piece of the puzzle for us. And just forcing an implant into a square peg into a round hole isn't always necessarily the best treatment planning for us. And if we have the peg that fits that hole, are we doing a better job treatment planning our patients? And so I oriented the implant with the bevel towards the distal buccal. No grafting was necessary, no osteoplasty was necessary on the mesial aspect, and not compromising the periodontal health of the tooth mesial to the implant. And so this is the radiograph taken immediately after surgery, preserving all of the bone in 360 degrees around the implant. And then we can see the final restoration is in place, and radiographically what we're able to maintain, not compromising periodontal attachment levels on adjacent teeth, not compromising bone levels on the implant. And we can see over time that our bone levels remain stable using this profile implant in this type of situation where we have an uneven crest. Certainly it is not a big deal for us to do some osteoplasty and take out a chisel or a rondura and flatten that bone, but then are we creating a step which may compromise oral hygiene for the patient? And here we don't have to do that. So the profile implant really builds on this Astrotech implant that has been around for over 30 years with the biomanagement complex, which is really what drew me to it about 7 years ago. Using that OsseoSpeed surface that we know will osseointegrate quicker than most other surfaces, the micro threads which better distribute force in that cortical bone at the crest and maintain the bone, the connection, that conical seal with virtually no micro movement of the abutment within the implant, and that contour, we're not going to use the word platform switch, but that connective contour, or moving that abutment implant connection horizontally away from the original crest of bone. And these are all the virtues of the implant that have led to that bone maintenance and that beautiful soft tissue health that I've come to expect using the system. And using EV, it lets me use one surgical tray to place narrow implants, wide implants, short implants, and the profile implant, I only need one surgical tray to place all these different varieties of implants for the specific situation for my patient. Now, as I mentioned, this implant, the EV implant, was originally designed for situations like this, where we have a sloped ridge and we don't have to overseat the implant, perform any kind of bone removal surgery, but place the implant exactly where nature provided its site without losing any of the surrounding hard and soft tissues. And these are just a couple examples of the EV profile and how I use it, and it circumvents the need for any kind of augmentation for the patient. And again, this is an implant that is based on a long-term, well-studied design where we see that even at 12 years out that these single unit implants virtually lose no bone around them. The bone maintenance is something that us as periodontists we're always concerned about because we're the ones that are going to have to repair bone loss around the implants when it becomes a problem for our patients and our restorative dentists. And having used many systems over the last 21 years, this is the one that I've found most predictably maintains that crestal bone. So let's look at another application here of the EV profile for patients with thin scalloped phenotypes and using it in the aesthetic zone. And what we know from the classic literature from people like Arnie Weisgold is these patients with these thin scalloped periodontiums often have a facial dehiscence that's more exaggerated than those with a thick flat periodontium. And that soft tissue is primarily supported by circular fibers after extraction. All the other supracrestal fibers are tooth dependent and are gone once the extraction occurs. And so if we have an anatomically correct implant, this may be the most appropriate selection for these types of thin scallop patients, where we know we have a greater disparity between the proximal bone crest and the facial, and we have an implant that is really designed to fit that situation for us. And a study that was not a new study, but one that really made a lot of sense when I was thinking about implant selection and using profile was the Loma Linda group that did bone sounding around implants that were placed with the head of the implant about 3 millimeters apical to the facial gingival margin. And what they found was about 6 millimeters exists proximally when bone sounding is performed. And we know the papilla is supported from the bone on the proximal surface of the adjacent teeth. But in terms of long-term maintenance, cement being a possible issue, and peri-implantitis becoming a more and more increasing situation for all of us to deal with, maybe we can make this a little bit better. Maybe these numbers don't have to be quite so deep. And we know that most of the current implant systems available to us today are really not designed for this type of thin scallop periodontrum, but they are flat-topped. But if we're going to stick to the rule of 3 millimeters below that gingival margin, how does this change? How does knowledge of the anatomy and the behavior and extraction socket change our implant selection? And if we're going to keep our implants on average 3 to 4 millimeters apical to that facial zenith of soft tissue, following that rule, wouldn't it be better to have an implant that was 1.5 millimeters more coronal on the proximal and palatal aspects? So maybe that bone sounding then would result in a 4 millimeter depth, something easier to clean, something easier to maintain cement from, and something that would maintain bone that would help us maintain our proximal soft tissues. And this is an implant that has been proven to be effective in immediate temporization in the aesthetic zone. Nolken did a study at 3 years with very high aesthetic scores. And so let's look at an example here of a patient, a physician in my area, severe external root resorption on tooth number 6. And I think you can appreciate the significant scalloping from the proximal to the midfacial that exists here on this patient who's had very little dental care up until recently. And so here we place a 4.2 millimeter straight EV profile, and we confirm primary stability. And what do we know happens? Well, at this point, only thing that we have under that facial soft tissue is bundle bone, which we know as periodontists is dependent on the presence of a tooth. And once that tooth is extracted, that bundle bone is going to disappear. It has embryologically lost its purpose. So again, the tooth is extracted, but it's not totally useless just yet, because we can now use it to help us in making our supracrestal contours of a provisional restoration, not our submucosal, but supramucosal contours. So we make a screw-retained provisional restoration. And another aspect that I think we have to focus on is the angulation of the implant. Many authors, including Bach Lee, an oral surgeon from Southern California, showed that the tissue thickness decreases as the angulation of the implant becomes more and more geared towards the facial. And we really want to try to have a palatal emergence of that implant within the socket to keep our soft tissue thickness at its maximum dimension. So the implant is placed in a palatal portion of the socket. The socket is grafted with a composite graft of bone allograft and xenograft. And here I use the subepithelial connective tissue graft to augment the thickness of the soft tissue, which hopefully will preserve not only aesthetics, but the thickness and the height of the facial bone. And we've seen that we can leave a portion of these connective tissue grafts exposed as long as the majority is receiving blood supply from the periosteum. And this has been shown that with the Loma Linda group, that if you do not do any kind of augmentation and you just extract a tooth, place an implant, and temporize that implant, that over time, that the tissues will continue to recede. The bone will continue to move in an apical and palatal dimension. The blood supply from the overlying facial soft tissues will continue to decrease, and we will have continued recession over time. And at 1 year, you are not out of the woods. But on the average of 4.5 years, but up to 8 years, they continued to see more and more soft tissue recession. And we've seen early healing at 6 months with Uli Grunder, that he was able to preserve the dimensions of these sites using an autogenous connective tissue graft. And again, the Loma Linda group showed not only the horizontal, but the vertical height of the soft tissue is better preserved when a xenograft is placed in the void between the implant and the socket walls, and a connective tissue graft is utilized in a combination therapy. So this is 2 months healing. And at this point, at about 12 weeks, the general dentist is fabricating a custom a custom impression coping based on the contours of the provisional crown to more accurately capture the soft tissue. And I know that I'm probably not the only periodontist that's received a call saying, hey, I took your healing abutment off, I took your temporary off, and it was bleeding. Is it okay to take the impression? And I would just, and if I am the only one, let me share with you what I tell the dentist on the other end of that phone call is not to worry about it. That the group from NYU showed us that when these provisional crowns are removed for the first time, when there was bleeding, this actually resulted in greater ridge dimensional preservation, because the thought is that provisional restoration provided an early seal and contained our graft and our clot. So we don't have to worry if we see some bleeding. We're just tearing some of those epithelial cells off the lining of the sulcus, and not to panic. So here is the Atlantis custom abutment in place and a cement retained restoration. And you can see where we started and where we ended with some nice ceramics by the lab and the restorative dentist. Another example, this is a patient of mine who's been coming to the office longer than I've been in the practice and recently moved from the burbs to Center City, Philadelphia, and she was walking on the street and tripped and landed right on her face. And cracked tooth number 9, number 8 was symptomatic, and to prove that I'm still a periodontist and I don't want to pull everybody's tooth that hurts, I sent her to Louis Rossman, past president of the American Academy of Endodontics in Philadelphia, and he did root canal with tooth number 8 and saved the tooth, but number 9 had to come out. So again, a thin scalloped periodontium, a profile implant is in place, primary stability is confirmed, and what we know with these patients that have the risk of recession is that by under-contouring the submucosal aspect of these provisional restorations, we can encourage coronal migration of the soft tissue. And so it's very important that I under-contoured this portion of the provisional restoration. We don't want to put pressure on this tissue because the only thing that can happen here is more recession. So for this patient, we obturated that gap between the socket walls and the tissue zone with a composite of the porcine allograft and the mineralized bone allograft. And after we try in and we confirm, we perform the dermal apron procedure, which I'll just talk about briefly, but we'll talk about quite a bit on Tuesday. But this is the perioderm material that is adapted over the screw-retained provisional crown that is under-contoured, and a few sutures are placed just to stabilize and lightly compress the soft tissue. And this is the completion of surgery the day the patient shows up. She walks in without any kind of tooth there, wearing an Essex retainer, and she's able to walk out with a tooth that is not in occlusal contact. This is 5 weeks after surgery. And at 5 weeks after surgery, I was very happy radiographically, but I was even more happy with the height of the soft tissue that we were able to actually gain about a millimeter of soft tissue height, where now we have some asymmetry in the good direction. And I almost didn't show this case because I saw her earlier this week when she was in for maintenance, and I hadn't seen her. She had the final restoration placed, and she called my office 2 days later to say that she was having pain. And I said, well, come in and let me take a look. And then she said, well, I'm not going to come in because it's too much of a hassle to drive out to your office. I don't know why she called. So she went to see the general dentist that restored the implant, and all I had was the x-ray from his office. And he called and he said, everything's fine. Everything is fine. Well, he didn't under-contour the abutment and the final crown, and so all that work that we did to try to encourage that soft tissue to migrate, he chased away again. And the pain was from the pressure being exerted by the material. But fortunately, her lip line is not really showing this, and she's not displeased. But I show this more for an educational, to make an educational point about the importance of contours of the provisionals and final restorations, both above and below the soft tissue margin. Now, the dermal apron technique article was in the Journal of Aesthetic and Restorative Dentistry last year, where we talk about the technique. The study we'll talk about Tuesday is in submission now for publication where we measure tissue thickness. But briefly, after the screw-retained temporary crown is made, we typically will use the thinner version of the perioderm, use a disposable tissue punch, pierce the material. The basement membrane portion is laid against the bone and the bone graft and abutment material, and the connective tissue side that is here laying against the facial surface of the temporary crown is going to be in contact with the periosteum from a small subperiosteal pouch that is created. And that is to encourage integration of the dermis to the surrounding soft tissues. Now, my reason for using the perioderm, other than some of the other dermal allografts, is that its working properties are much, much better. Its tensile strength, its modulus of elasticity. It's also not saturated in antibiotics, so it incorporates with the surrounding soft tissues, and it doesn't hang around and smell awful like some of the other competitive materials. And I first showed this in a PRD article a couple years ago, using this with immediate placements to serve as both a barrier or guided bone regeneration and to thicken the peri-implant soft tissue. So talking about the phenotypes of our patients, we have differences in terms of the scallop of the underlying hard tissues and the soft tissues, and this is really where the profile implant shines. So this is a patient I treated a couple years ago with a fracture of tooth number 8. We placed a profile, we did a dermal apron procedure around her immediate temporary restoration, and we always capture this for the restorative dentist so they see where the screw access is, especially if it's towards the incisal or the facial, and the tooth is contoured so it is not in occlusal contact. So this is the case when it was completed about a month after delivery of the final restoration. This is 2 years later. And 2 years later, we have stability not only radiographically of the bone, but of the soft tissue, and the soft tissue actually over time becomes more and more of an even blend with the surrounding soft tissues, trying to make it as inconspicuous as possible. What about multiple anterior teeth? And this is a patient who I've been treating for a long time, has one of the worst parafunctional habits I've ever seen, breaks everything. He's bitten through multiple night guards that I've made for him and needs replacement of this 3-unit bridge in the anterior. So we're going to use a 4.8 conical implant, let me go back, for the central incisor, and we're going to use a 4.2 conical here for the lateral incisor because we have plenty of space mesiodistally. Again, with palatal placement, these are both profile implants. We confirm our stability with resonance frequency. We graft the gaps with our composite bone graft, and then this is the perioderm punched, trimmed, and tucked subperiosteally around both of these implants, around these healing abutments. And so we have single stage placement, and the patient's going to wear a transitional partial denture that he broke about 7 times. And this is what we look like at 10 weeks. And I think you can appreciate the thick, healthy, soft tissue. We're not having any shine through of the smart pegs here. We should be able to mask abutments relatively well and maintain our bone. So this will take us into the issue of primary stability. And last year I published a study looking at 59 consecutively placed immediate implants in single rooted sites and trying to see if there was a correlation between insertion torque and implant stability quotient. And this goes to a recent paper that Michael Norton published where he looked at insertion torque. And he had 30 implants that had a lower than 20 Newton centimeter insertion torque, but saw relatively favorable ISQs at time of placement and significantly higher ones at 12 weeks. No implants were lost and virtually no mean bone loss using the EV implant system with very low insertion torque, which calls into question the importance of really excessively cranking these guys down. And I know there are people out there that will say, well, there's no such thing as pressure necrosis and it's all BS and they all work and don't worry about it. But there are reports in the literature to the contrary. And the one animal study from Belgium showed that with the experimental implants that required greater than 50 Newton centimeters, significantly greater bony defects and bone resorption compared to control implants. And a human study from Italy showed the same thing, that when implants were placed with a high insertion torque in healed sites, there was more crestal bone loss and there was more soft tissue recession compared to those that were placed with a lower insertion torque. So I don't think anybody's going to make a consensus decision today, but I think that there's room on both sides for continued discussion here. So in our study, we followed an EV drilling protocol. We did not undersize any of the osteotomies, no osteotomes were used, and we didn't use any of the accessory V or X drills to widen the apical portion or the entire dimension of the osteotomy. Standard EV drilling protocol. And when we look at resonance frequency or the ISQ, what are we measuring? Well, we're measuring the stiffness of the implant itself. We're measuring the interface of the implant and the surrounding bone. And we're also looking at the stiffness or rigidity of the bone. But what we're really looking at here is axial stability of the implant at any given time. And for those of you who do this, it's a relatively easy process. It takes under a minute to perform. And then we have numbers that we can go back and look at follow-up. And what we know from ISQ historically is the higher the value, the more readily we may feel that we can immediately or early load these implants. Now, insertion torque is different. It's really a measure of the cutting resistance of that implant as it's being seated into the osteotomy, and it looks at rotational stability. But you can only do it once if you're ethical. So this is not a repeatable measurement for us. So what I found in the study here was all 59 of these consecutively placed immediate implants integrated, received definitive restorations. The range of insertion torque was really wide, from 20 to 50 Newton centimeters, with a mean ISQ of 28, and mean ISQ of 68 and insertion torque of only 28 Newton centimeters, which could be considered low. But we were not able to find any correlation between insertion torque and implant stability for these single-rooted sites with immediate implants. Now, interestingly, pertaining to what we're really talking about today, is there was a subset of 13 patients that received 14 implants, and their mean insertion torque was only 23 Newton centimeters, and an ISQ was 69. And if you look at the literature, 23 is probably too low for about 90% of clinicians to assume that immediately temporizing these cases was safe. Well, we look back at some of Michael Norton's earlier work, and he used 25 Newton centimeters as a baseline for immediate temporization and had extremely good results at 2 years out with almost no bone loss, and looking at almost 10 years, these implants were maintained in a state of health. So again, calling into question insertion torque and its value in terms of when we can immediately temporize implants. Now, there are conflicting reports, and Malchiodi showed that there was a correlation. But in that study, they undersized their osteotomies. They intentionally compressed the bone apically, and they used posterior sites. They were using bicuspid and molar sites engaging the septum of bone. So we're really not talking about the same thing. And we've seen in animal studies that when bone is compressed or densified, that we see microfractures after the procedure, and long-term, we see crestal bone loss, or these craters. And this is an implant that I had to place with a ratchet, and at 6 weeks, this was that kind of crestal defect that I found, where I really had to insert quite a bit of insertion torque to have the implant seat completely. So the clinical reality would be that if we were going to use an excessive insertion torque as a prerequisite for immediately temporizing these 14 implants in the study, what we would have wound up with was only 3 of those implants would have received temporaries. And that means 11 patients would have had to wear Essex retainers or flippers where they didn't have to. So you talk about building your practice and building confidence with your referrals and your patients. Well, sending somebody out of your office with an Essex retainer is certainly inferior, in my opinion, to sending them out with something like this. So why? Why did the EV implant perform the way it did? Well, I think there's something to the geometry of the implant, the micro threads, the thread pitch in general, the osseous speed surface. It's not just the surgeon, even though I'd like to say it is, but I think there's something to the implant. So we go back to this case, we obturate our defects with our composite bone graft, we use our perioderm, 10 weeks. Now, he's broken that temporary so many times, and he doesn't have a general dentist, and he refuses to let me send him to one. And so, amongst friends, without sharing this with the outside world, I made him a provisional, screw retained, just so he'd stop breaking that flipper, because it was becoming a tremendous detriment. And I restored his case myself with screw retained 3-unit restoration. And you don't see any shine through of the metallic components because that soft tissue is thickened using the grafting technique that I showed you. So we have a screw retained restoration and a new night guard. Another one of the patients in the study here, tooth number 7, needed to be extracted. He didn't want to spend the money on a provisional, and he was kind of a jerk, so I was happy to make him an Essex and tell him to live with it. But again, the insertion torque was relatively low, but his ISQ values were pretty high. We had really good axial stability of the implant. He could have had a temporary, but I wasn't throwing it in for him. So anyway, we do the same kind of grafting procedure around this 3.6 millimeter EV implant, and you can see the health of the tissues at hard and soft tissues at 8 weeks. And we've had a slight increase in our stability. And this is the final screw retained restoration for the patient. And we've had nice thick tissue. We don't have any shine through of the components. So if a patient comes and he's got a fractured central incisor and he's got a scalloped periodontium, and I don't really know this guy, and I really don't know his dentist all that well. I'm not sure why he sent him to me, but I didn't want anything to fail here. So we treatment plan, and we look at the cone beam, and we see the disparity between the palatal height of bone and the facial height of bone. And if we put a flat top implant in, where we're going to have to do more grafting. So rather than doing that, we place an EV profile implant, which is going to fit this anatomy much more predictably than a flat top implant. So the tooth is extracted, a profile EV is placed with primary stability, and we have an insertion torque of 30 Newton centimeters and relatively high stability quotient. So we do our dual zone grafting with our particulate, a dermal apron. We really want to keep this out of occlusal contact. He didn't care, he just didn't want to wear something removable. And so this is how he leaves the office. This is 5 weeks later. And even though we have a short tooth, aesthetically, this man does not care, but it is not in occlusion, which it would have been if it was the length of the other central incisor. But the bone has really not moved from the time of surgery. This is 10 weeks. And this is the final restoration. And we've been able to maintain our soft tissue, contour, thickness, papilla height, and most importantly, our bone levels proximally around the implant. And this is where we started, and this is at the end point of treatment. Another number 9, same thing. We take our cone beam and we treatment plan. An EV profile is placed, so we don't have to put the proximal level of that implant fixture 1.5 millimeters deeper to correspond with the facial position of the implant where it needs to be. We test our stability. We graft, always grafting up above the bone level with our particulate, and again, a dermal apron procedure is performed, and we close. And again, out of occlusal contact, patient's made aware that a tooth is going to be shorter. Again, does not care, he just doesn't want to wear something removable. But we have an implant that would have been placed 1.5 millimeters deeper proximally had we used a flat top fixture versus the profile. This is at 7 weeks. His plaque control is not great. I did a little cleaning up. That's why you see a little bit of bleeding and inflammation. And this is the completed restoration. So when we make screw retained, I think I have enough time to get through this. I gave the course at the AAP for a couple years on making temporaries for the periodontist. And I will tell you, I have some dentists that make them, and I trust them, and they don't cause any problems with the case. And I have some that I absolutely do not trust, and I insist on making the provisionals. And so this has really actually become a practice enhancer for me provisionalizing implants because I have some referrals that want me to do it and tell the patients that I can do it. And this is really a technique that I think if you can master, and it doesn't really take a long time to master, can really help you grow your practice and bring new patients in. And so some of these are from the course that I gave here at the AAP. What you first have to do is acquire a model either before the tooth is extracted, or if the tooth is already missing, have a model. I have a box of denture teeth in the office, and one of my assistants loves waxing in those denture teeth just to get me to the point that they can duplicate it and make a vacuform template. And so this is what you need before the surgery starts. You can use this as a surgical guide as well as to help you fabricate the provisional restoration. Now the temporary abutments, you can acquire, Dentsply has them in both the PEEK material or the metallic. I usually use the metallic. I find them easier to work with. Most of the time you have to do a little bit of modification on the facial, but you place the temporary abutment into the implant. If you're doing this flaplessly, it's a good idea to take a radiograph and just make sure that you're seated all the way. And then I start my grafting. I will pack this area with my composite of allograft and xenograft. And then you find out where that vacuform template is going to sit. Where is your screw access going to be? And then you can use a bisacryl material. This is the Integrity from Dentsply. But what you'll do is, and I will tell you, it is critical to trim that vacuform template. So you can use, I use the flat end of one of the plastic instruments to make sure that you don't lock into the undercuts with the adjacent teeth. And this shows a laboratory screw. To be totally candid with you, I use the medium length hex driver from the surgical kit because it completely fills the space of that channel through the temporary abutment into the screw so none of that material can lock in. And then you know it's engaged in the hex. And once this material sets in a couple minutes, you can just take it off. So I'll make a hole on the facial, a hole on the palatal, and inject this material in to capture as much of the contour as possible. And after a couple minutes, it's set. You just unscrew that. This pulls off. This shows rubber dam. It's always advisable to use rubber dam. Sometimes, honestly, you can't because with a flapless placement, you won't be able to get that rubber dam deep enough where you'll have enough of the abutment to engage and lock into to pull this off. But what you'll do is you'll pull that off, and you'll have a portion of the temporary abutment that does not have any of this bisacryl material in it. You place it into a replica or an analog, and then we'll use a flowable composite to fill the voids and just hit it with the light to fill all those voids, and then use the Midwest burrs to do the rough contouring, and then you have either the pogos or the different types of discs. These are relatively inexpensive, and just do all your fine tuning and contouring. And at that point, what I'll do is I'll make sure that I don't have to do any more of my bone grafting, if we have to do any more of the dual zone grafting to get it just about to the height of the soft tissue margin. And then I have the titanium coated periosteal elevators in all of my implant kits. And I like the sharp end of the boozer. And I'll just, now this model was made too short, but what I'll do is I'll just form a little subperiosteal pouch between that facial bone and the palatal bone, and 3 to 5 millimeters maximum in a coronoapical direction, punch the perioderm, and make our dermal apron. And then we finish the contours and we seat it. And before we tighten that screw and torque it to 15 Newton centimeters, we take a radiograph and just confirm that everything is seated all the way. I always try to take a photo for my restorative dentist as far as with the screwdriver in place, so they know where to remove the composite material, take out that Teflon tape so they can take this off to take their impressions. And then this is delivery of the provisional crown on the model, and this is one done at time of surgery. So what is the future of immediate implant therapy in the aesthetic zone? Again, diagnosis, recognizing your periodontal phenotype of your patient, Choose the implant based on the anatomy. If you have these thin scallop patients, using something like the EV profile may preserve bone and not force you to seat that implant as deeply 360 degrees as you would with a flat top implant. Palatal positioning of the implant within the socket, trying to get a cingulum or palatal access is very important. I think augmenting both hard and soft tissue, I gave you some suggestions. I think for long-term aesthetics is very, very important. And you have to be meticulous in your contouring of your provisional and your final restorations, both above the soft tissue height as well as apical to the soft tissue height. And so for these types of thin scallop patients, I have found more and more use of the Profile EV in my practice for canine and central incisors. And with that, I thank you very much.